right, welcome everybody to University of Washington in Seattle, Washington in the United States. I'm Jamie McCabe. I'm so happy to be here and honored that we might be invited to present for ANZET 2021. I'm joined by an outstanding group of collaborators and colleagues, my good friend, Dr. Gabriel Aldea, CT Surgery. Over here, let me get this out of your way here. Dr. Srjdan Jelacic from Cardiac Anesthesia, who's going to be doing all our imaging for us. Dr. Christine Chung, one of my colleagues in interventional cardiology. Our fellow, Dr. Logan Vincent. Bailey Benton. Paul in the back. Just a terrific team. So we're really pleased to be here, and we've got a very interesting case for you today that I hope you'll enjoy. Logan, would you give us a little introduction?
Love to. We have with us today a 78-year-old woman who was found to have severe mitral stenosis with significant mitral annular calcification, as well as mild to moderate aortic regurgitation. She presented for cardiac evaluation with New York Heart Association class 3 to 4 symptoms. Her medical history is as you see here, otherwise hypertension, hyperlipidemia, fairly well-controlled diabetes, known carotid stenosis. Transthoracic echo showed a preserved ejection fraction with normal wall motion, very severe mitral annular calcification with a mean diastolic gradient across her mitral valve of 18 millimeters of mercury at a heart rate of 92 beats a minute. There's also moderate AI on that study. Relevant cardiac medications include attempted rate control with metoprolol and lisinopril for blood pressure control and some cholesterol medication. As part of her workup, we then obtained a CTA of her chest, abdomen, and pelvis. These images are from the analysis of that study in preparation for transcatheter mitral valve replacement. Notably, we're taking a look at her intercommissural distance, which measures 29.6 millimeters, and her anterior to posterior distance, which is 23 millimeters. So looks like very favorable measurements for a 29 millimeter Sapien valve. Notably on the image below, you see that she has circumferential mitral annular calcification, so good targets for anchoring this transcatheter valve. We can see the green box here is essentially what the Sapien 3 valve would look like when implanted in her mitral annulus. The orange line in her left ventricular outflow tract and then outlined area on the bottom right gives us a sense of what her neo-left ventricular outflow tract would look like. This measurement was quite small at 96.3 millimeters squared. This is essentially her skirt neo-LVOT, so what this area would look like if we performed laceration of that anterior mitral leaflet or a lampoon procedure. This is a much more favorable left ventricular outflow tract measurement at 207 millimeters squared, still somewhat borderline. So based on these results, decision was made to perform today's procedure with lampoon as well as alcohol septal ablation to hopefully produce hypokinesis of that septal knuckle to optimize her LVOT after valve deployment.
Great, thank you, Logan. And then Serge, why don't you take us through the TE a little bit, what we can see on the screen?
Yeah, so the intraprocedural TE basically confirms the pre-procedural findings. There's a severe mitral stenosis with circumferential severe mitral annular calcification. And as you can see, there's quite a bit of calcium on the valves as well. And if you can see here on the 2D imaging, the anterior and posterior leaflets are quite calcified with a small opening, which on planimetry calculates to about 1.8 centimeters squared. The anterior leaflet measures about 2.2 centimeters, and the LVOT about 2 centimeters. There is severe ventricular hypertrophy, as you can see on some of these images, with a trace or small pericardial effusion. The mean diastolic mitral valve gradient is between 7 to 8, and the LVOT gradient under general anesthesia is measuring at 5, so that's not significant. You can see that here.
That's terrific, thank you. So one of the decision trees to make in these cases is how to stage the risk mitigation for outflow tract obstruction. And in her case, a skirt neo-LVOT of 206 is really kind of borderline in my estimation. I think, you get over, say, 240 and you're really in the clear with Lampoon alone. Certainly under a skirt neo-LVOT under 200 makes me pretty nervous. So these are, when you get a really small skirt neo-LVOT, we tend to favor doing alcohol septal ablation preemptively in its own setting and then coming back and remeasuring or redoing the CT scan, remeasuring the neo-LVOT. But in this case where 207 is, by some people's measures, perfectly fine for outflow tract hemodynamics, I think just doing a quick alcohol up front can help just make sure that that hypokinetic area is not a problem. Of course, we just, as often happens in these cases, we just took a first angiogram, and you can see kind of hiding back there is a proximal LAD lesion that we did not anticipate. So this might become a little bit more than we thought it would be. And just in terms of access that we did offline, we've got a 24 French dry seal in the right femoral vein. That's going to be kind of our working sheath. We also have a arterial sheath in the left femoral artery and an arterial sheath. That's kind of just a bailout in the right femoral. I don't have an intention for that other than that after Lampoon, if she were to get sick, that would be where a balloon pump would go in very quickly. We also have a temp wire that's in from the neck, given the alcohol septal ablation and the potential need for that to stay in a little bit longer. Let's see if we can visualize these septals a little better. So we're going to go steep RAO crani. That's better. Okay. All right. Well, so we see I think the septal target here is kind of that first larger septal and then going towards the more basal branch. And we'll drip in some Definity to see where that lights up on the TEE. But then you can also see that we're probably going to need to just fix that LAD briefly after that as well. So, all right, can you pull the wire back? This is just a 2.0 over the wire balloon with a workhorse wire through it. All right, so with some challenge, we got down this one septal that we think could be a candidate for septal ablation. And we've got some echo contrast here, and if you could flip those two for us, please. So Serge is gonna, yeah, perfect. And then we're just gonna blow up this 2.0 balloon here in the septal and drizzle in some half and half Definity. I always make it half and half because it kind of flushes through and then it lingers for a while, which can be confusing after it gets. I see it in the. I don't know. Do we really? It's kind of lighting up there. The septum.
Yes. Yes.
Okay. Good. It's not
over here. Yeah.
Yeah. It's not perfectly in the knuckle, but it's. Yeah. But it's not bad. So I think that's what we're going to take. All right. So let us have some. Can we have? Here's a Definity back, Bailey, and we will take 1 point. So we measured the interventricular septum at 1.6 centimeters.
Correct.
So you got that too?
Yes.
Oh, perfect. And that's what the CT also suggested. So we're going to use 1.5, roughly 1 per. So we'll use 1.5 of pure alcohol dripped in over a couple of minutes, which we won't make you watch the totality of. But we're just going to slowly drip that in with the aim at this junction that the septum simply becomes hypokinetic. We don't expect it's going to atrophy or apoptose immediately, but it will become hypokinetic, hopefully, which actually goes a long way towards improving neo-LVOT in our experience, and that's sort of how bailout alcohol septal ablation works as well, right? That it obviously does not create a scallop in the septum immediately, but it can create akinesis. So, Srjdan, at this point we infused about a cc and a half of pure alcohol into the septal branch that we were interested in. We then waited 6 minutes during dwell time. Why don't you give us a little update or comparison on what kind of effect we got?
So this is the just immediately before we infuse the alcohol. You can see the basal septal segment here, and there's essentially a normal motion here. And then this is now an image after the alcohol infusion.
Yeah.
There's quite a bit more hypokinesis.
Great. So that's what we're going after. I mean, in these kind of acute settings, you're not going to see apoptosis or scalloping of the interventricular septum. You're just looking for hypokinesis or even akinesis. At this juncture, we're going to move ahead and treat that severe LAD lesion that we incidentally found and get that taken care of. So we'll do a little balloon dilation, an IVUS, stent, post-dilate, and then we'll move ahead to the main event. Okay, beautiful, very good. All right, and you can see also in that shot that septal that we ablated now has basically TIMI 0 flow distally, so that also worked nicely. Okay, let's get back to doing structural heart work. We can take all this stuff out and it can all go on the back table and we can move ahead. So first step in these cases is going to be transeptal crossing. So we prefer to use the VersaCross system. It is an electrified wire system. Here it's just a little bit more convenient, and for those difficult septums can be a really nice way to get across if you've got like a post-surgical septum or something like along those lines. So VersaCross system is a purpose-built wire. As you can see, it's circular or pigtailed, and the tip of it will conduct electricity. So I'm going to pull that down. Can we put the echo bigger on our screen, please? Thank you. We would like to cross posterior or inferior so that when we're delivering the valve, we're going to spend as little time as possible in the right atrium. So, ready? Go ahead. Thank you.
Across.
Thank you. Okay, so we're just going to bring this guy across and take the dilator out, but leave the wire in place because ultimately we're going to need 2 wires across this septum. You want to just walk that back? And so we're going to take a second wire, the Amplat's extra stiff wire, next to this purpose-built wire. What we're going to do now is bring in 2 steerable catheters. There are multiple manufacturers, and I don't know that it matters terribly. We use a Boston Scientific product called the Direx, which is probably less well known than an Agilis. The upside from my standpoint for Direx is simply that it is an 035 lumen to the dilator, so you don't have to use the dedicated wire, which always made me a little annoyed. Can we have the JR4 on a J-wire, please? So these steerable guides are both across the same interventricular septal hole, and we're just going to label them. Okay. So the more interior one we're going to call the A, which is for atrial, and the other one we're going to call V, and now we can just distinguish them. We'll take this JR4 and we're just going to put this in the aorta. So here we're going to take the 1830N snare, and we're just going to put it in the ascending aorta right above the aortic valve, and it is going to hopefully catch our R350 delivered through the mitral orifice and then out the aortic valve, if I can get it to out of all this stuff. There we go. And so that's out the aortic valve. Now, did we catch it is always a question, and the answer is it fell back. Okay, let's see if that did it. Okay, so now I've got it. So there's me snaring the wire, but I've actually caught it at a part where it doesn't fold so well because it is nitinol, so we want to get back onto the tip of the wire. So I'm going to let the snare go just a little bit and pull down to the radio-opaque segment, and then we can externalize. Okay, right about there. Okay, good. So now we're just going to externalize this R350, which is here. Yes, please. All right. So, and then let's take this balloon wedge out. So at this point, we have an externalized wire that goes from the vein through the interventricular septum, through the mitral valve, through the aortic valve, and then ultimately externalized through this JR4 catheter. The purpose of this JR4 is just to hold the EBU 3.5, which I have here, and this is an 8 French. It's just to hold it into the outflow tract after it goes through the mitral valve. Okay. So that's all this really does. If you don't, we've tried to skip this step before because there's a lot of steps here. So we've tried to skip it, and skipping this step means that the JL just sort of flops back into the ventricle and does not sit in the outflow tract on the ventricular side of the anterior mitral leaflet, which is where you want it, because it's going to hold your next snare. Struggling to get underneath. Okay, let's pull this guy back while we pull this guy forward. There we go. Okay. All right, so that just popped in there, and we can show you that this way. So now this JL, as you can see here on fluoro, is through the mitral orifice and underneath onto the ventricular side, and we're going to bring the same snare, the 1830N snare, we're going to bring that back into the body through the JL and just leave it in the outflow tract. And then we're ready to receive the electrified wire that's going to fenestrate the anterior mitral leaflet. Okay. So now through the other directs that we've been ignoring for a while, labeled A, we're going to bring up a JR4 with a copilot. So we're going to take this JR4 up through the directs on the atrial side of the anterior mitral leaflet, and then through that we're going to take an Estado, 20-gram tip Estado, 300 centimeter length, with a piggyback, which is a microcatheter, and frankly it could be almost any microcatheter that doesn't have a metal braid. We just use plastic only microcatheters, so you could use a fine cross or quick cross or anything along those lines, but not really a Corsair or a Turnpike because of the metal braid there. Can you just pull this back, please? Thank you. So this is going to go right inside the JR4, and that's how we're going to penetrate through the anterior mitral leaflet. All right. So just bring this up to the tip of the JR4. Okay, and then your wire has been pulled back. Okay. Tip of the JR4 and wire. Okay. So Serge.
Yes.
We are going, let's see, it looks like we're quite posterior, so I'm going to rotate anteriorly and unflex to come towards the midline.
Can I just orient the views here?
Yeah, please do.
So left hand top corner here is the mitral commissural view. Right top corner is the long axis view. 2D on fast view and 3D on fast view, the aortic valve at 12 o'clock.
Perfect. And it looked to me earlier like there was 2 boulders of calcium on the anterior mitral leaflet with a little bit of free space right
In between,
them.
that's right.
Okay.
Right around this area here.
Yeah. So I'm trying, and that's my catheter there that I'm trying to get to face right in there.
More toward the base. There we go.
Yeah, somewhere like that. On the 3-chamber-ish view, upper right. Oh, I see. I went too far lateral, so I can pull back a little bit, and I can also, flex a little bit more, and I came off, but that's okay. So we're gonna now rotate this JR4 anteriorly. Come back here a little bit, like that. And on fluoro, it looks like they're kind of nicely aligned, pointing to the LVOT snare. What do you think of that spot?
Are we close enough to the base?
That's what I'm wondering. Yeah, I think that's a good point, Gabriel.
Okay.
Maybe going a little more towards the base.
So if I take my steerable catheter and I rotate it anteriorly, I'm going to come up towards the base a little bit more. Looks like it's all kind of calcium up north of me there. I don't know. What do you think? I can come further towards the basal A2?
Can I have something?
I think so. If you can.
Dilator.
Okay. I'm going to try and come up here a little bit more.
This looks like a lucency a little bit more medial. If we have to tear.
Okay. So I can pull my JR4 back a little bit, come a little more basal that way. What do you think about that spot?
Yeah, that looks better, yeah.
Okay, so at this juncture, Dr. Chung is going to be on holding the microcatheter with their left hand and the wire with their right hand, and Gabriel's on the Bovie pen. We set it to 50 cuts, not coag. So we're in concert here, kind of a 3-person thing. I'm holding the angulation of the system. Gabriel's going to go on with the Bovie pen, and when Christine hears the electricity going, or the Bovie pen going, she's just going to advance the wire out of the microcatheter a centimeter or so, and we're going to see if we fenestrate. Now, if the wire just bows or bends, it means that we're on a chunk of calcium, and the electricity simply will not penetrate through that calcium. So once we see a bow or a bend, we're going to let go of the electricity so that we don't make any kind of linear slices in the atrium, and Christine's going to stop pushing. Okay? So that is our plan. Are you guys ready?
Yes.
Yes.
All right. Bovie on? Yep. Okay, good. Bovie on.
Perfect. See the air, so we're good.
So you see the bubbles, which suggest that the electricity certainly happened. What do you think? I know it's really hard to see with all the subvalvular calcification.
We clearly have something across.
Yeah, well, we have it across. It's just, did it go through or did it go through the orifice? I think it went through. Unfortunately, we missed our snare, which is always a bummer because that's sort of the hardest part, is grabbing it with the stupid snare. But okay. Okay, so let's carefully walk this microcatheter off. We're gonna do a balloon assisted lampoon anyway, and we're just gonna do that part first. It's gonna help us have a little more mobility to snare that wire. Logan. Oh, there we go. Okay. So we just had to orient things a little better. Yeah, if you go up, it's going to push the catheter right off. So we call this balloon-assisted lampoon, where we're taking a 4 or 5 coronary balloon and we're putting it right across. So that's interesting. I don't know if you saw that, but I think we actually just pushed the JR4 just popped through that very same hole. So let's just pull our JR4 back a little bit and pull this up, and we'll do it again. Okay. Here so we can see. There's the waist of the mitral.
Can you show it to us in echo?
Yeah.
So we're looking here slightly tilted on fast view of the mitral valve. You can see how we're nicely engaged at the base of the A2 segment, and then There's the tip of the proximal end of the balloon here.
And on the ventricular side?
It's a little bit busy on that side, but we can
Yes.
take a look here.
Down?
So what we're going to do now is just put this balloon. Oh, you can put it down. Thank you, Gabriel. So part of the reason to do this is simply that you know, if you make a slit with a narrow base and it opens like this, and the idea is that if at the base you make a larger opening and then you open, the whole divide of the lampoon can theoretically split wider. That's at least conceptually the idea behind this. It also happens to help when you're struggling to snare, that you can just put the balloon on the ventricular side and you worry less that you're going to fall backwards. So we were kind of struggling with snaring the wire because the steerable catheters are interacting a fair bit across the intraatrial septum, but nonetheless, we will persevere. All right, so let's bring this down. We have to get push our JL back there. Bring the snare out here. And snare is clearly sort of trapped among something because it didn't flare. Okay, come on. Try that. Okay, got it. Actually we have the balloon. Yeah. So here we go. So we just snared actually the balloon as well. I'm going to let a little bit on the snare.
Yeah, and I'll walk the balloon back.
Yes, please. Okay, is the balloon back? It's a little hard to see. You can walk it back a little further. Okay, so now we just have the wire, and we're going to involute that wire just a little bit. Okay. Good. So now we have involuted R350. We're going to push this guy out.
Green blade.
Yep. Okay, so now that we have involuted the estado from the atrial side of the anterior mitral leaflet to the ventricular side, before we externalize, we have a couple things we're going to do. Yeah, you can take that balloon out. So the first thing we're going to do is get rid of this R350 that was our externalization wire for the JL guide. And so we can just pull that guy right out because it is no longer necessary. Okay.
Take the piggyback.
Yeah. So here is the R350 that I'm just going to give you, and we're done with that. And the JR4 will just stay in for hemodynamic monitoring. Okay. Now, before we externalize the estado wire, we're going to bring the piggyback back on it that we took off for the ballooning, and it is a 150 centimeter.
No, it's the other side.
It's a 150 centimeter catheter that's going over a 300 centimeter wire. So it is going to designate kind of the halfway point of this wire for us. Okay. So there's the estado coming out of the piggyback, and now this piggyback is telling us where the middle of the estado is. So before we go any further, we are going to fix the position of this piggyback with the estado by using torquers on the back end that we can tighten. Thank you. So here's a torquer, and we're just going to tighten those down so that the tip of the catheter, kind of the green blade, okay, so that the tip of the catheter kind of stays where it is relative to the wire. Then at the tip, I need the green blade, please. Thank you, Billy. So at the tip, we are going to make a V, and we're going to denude some of the PTFE coating. So this PTFE does not really conduct electricity, and so the electricity is going to want, thank you, it's going to want to come out the tip, but we want it to be right at the tip of this wire. So we're going to take this, just shave off a little bit there, okay, and then at the shaved off portion, which is under my hand, we're going to just make a really tight little V with the back end of the blade. Okay. All right. just make sure that's nicely shaved. All right, so now we should be able to get externalized electricity to preferentially come out of this V, and we're keeping this relationship static so that we can see the V well because there is a radiopaque marker at the tip of this catheter. Okay, so now we can externalize this wire. So what we're going to do is bring this copilot back over the V because it's always a little hard to get it across there, like that. That's fine. And you're going to pull, and I'm going to push.
Want a hemostat on that?
That'll be okay for now. That's just the snare.
Oh.
Okay? Yeah. So now we're just externalizing the wire that we've snared. Okay, give me 1 sec.
Can you put the
Okay.
show it to me?
So that's just the wire being externalized. I need some slack here. Thank you.
Gotcha.
There we go.
Good. And there's the externalized wire. Okay? So there you go. And you put a little hemostat on here just so we don't lose it. Now we need to bring the V into position across the anterior mitral leaflet. So I'm going to still continue to feed until we see the radiopaque marker as we see there. And there's the V. Okay? Okay. Okay, good.
Okay, so what's our ICT? Great. Let me just check the position. Looks good. Are you okay for us to prep the valve?
Yeah, absolutely. So we're going to bring the two catheter back, right, here and here. And you can see that, so just I'll cine this so you can just see a little better. So now you can see that V is in the ventricle. We're going to just pull everything back taut but not tight to make sure we get all the slack out of the system, because one of the ways that this can be more challenging to cut is that if you inadvertently pull the V into one of your catheters, you know, pulling it across rather than just pulling the whole thing back as one. So, and that's certainly something we have done plenty of times. So we're just going to try and take all the slack out of there. Serge, are you good for us to
Yes.
tear?
And you can see your V fly on the 3D imaging here, and as well as a little bit here under the mitral valve on 2D imaging.
Yeah. Good. Thank you. I'm just going to pull this guy back a little bit. This guy forward a little bit. Okay. Yeah. All right, Gabriel, you good?
Yeah.
All right. So after this part, they sometimes can get sick because you have new MR, so we will be ready to move relatively quickly. Okay. Ready?
Yep.
Okay, Bovian. Okay. There it is. So once the bubbles go away, hopefully we'll see a nice new slice in our anterior mitral leaflet. At this point, we can get rid of our externalized wires, though they're often kind of caught together like they are right now. There we go.
How's the MR look?
There's definitely more MR.
Okay.
So, can feed, huh?
Yeah, so we're going to get rid of this guy. There you go. I'll take that. And we'll get rid of this guy as well by unlocking. Yeah, I see it. Thank you. Okay. We'll take. Why don't we take the. Actually, why don't we take the balloon wedge first,
Okay.
please?
Balloon wedge first. There we go.
Thank you. We'll take this chair for it. So now we just have to recross the valve. Thanks. We'll just have to recross the valve and put in our stiff wire. Thank you. Just a little bit. Okay. It should be a little bit easier to cross now that we made a big tear in it than it was before.
Pressure.
Okay, there it is. Okay. And then we're going to MAC out. Okay. All right.
Okay, good.
Okay, so let's take the balloon down. Okay. Yeah, you can walk that back. Okay. Now, we know from our CT imaging that this angle of 48 RAO is basically our deployment angle, and the calcium is largely just annular. It does not really extend down into the ventricle. So we need a balloon septostomy next. Yep. And so, so we're going to basically stay in this angle for deployment.
Want to balloon a valve?
Yeah, I think we'll just pop across the valve and make sure that everything delivers okay. Do you have the wire? Yeah. This will also just help us ensure, just watch the wire. It'll help us ensure that things are going to deliver okay. So I need. Okay, why don't you just go ahead up there for a second, Gabriel? Good. So this is a 14 millimeter balloon down. 14 millimeter balloon that we're using for the septostomy. We used to use 12s. Kind of gone to 14s just because it doesn't seem like it makes that much difference for the septum, but it. I think we missed it there. Just barely need to come back a little bit more. Doesn't seem to make that much difference for the septum, but definitely makes delivery a little bit easier. So there we go. Got it that time. Okay, and then one more time, just make sure that it's nice and open. Okay, good. And I'm just going to push that forward and then make sure it goes. Yeah, okay. All right, so a balloon septostomy is done. Lampoon's done. Alcohol septal ablation's done. We are going to bring our valve in. The valve is mounted, thank you, got it, upside down from TAVR perspective.
So IRX out?
Yep. Take our steerable.
It's sewn in.
Yeah, we're good. All right. There we go. Great.
Okay.
There you go. Thank you. So just for the sake of anchoring, we are using extra volume in our valve. The valve area was 606, but we're going to use a 29 millimeter Sapien valve with additional volume just to make sure that we really anchor well. Watch that wire. We want to keep that wire from bowing in the atrium. Okay. You can start to load there.
Okay.
Yeah, go ahead. One of the nice aspects of a 24 millimeter valve is that you could really even mount the valve practically in the sheath. Okay, now we're going to give this some curve here, but it needs to be upside down to face the right direction, like that. Good. Okay, good. Thank you. Make it to 10. Okie doke. So,
let me get on the correct side.
Sure thing.
You want to pace?
We will in a second. So, Paul, we're gonna ask you to pace in just a moment. This is a tough time for that to happen.
Pressure.
Okay, so I'm now going to straighten out the delivery catheter. It's nicely oriented, but unfortunately, once you pull the pusher back, the orientation gets worse. So by straightening out the delivery catheter, you can do kind of a push-push maneuver, where you push the wire and push the delivery catheter and just push everything over to the lateral commissure. And then it can deploy from the lateral commissure to the medial commissure, and that's sort of the goal.
And we want the dot just on the V side?
We want the dot, yeah, we want the base of the dot to be on the, kind of on the atrial side of the calcium band, yeah. So we're going to pace here at 200, Paul, and then after we're done pacing, rather than turn it off, you're just going to turn it down to 60, okay? And we're going to go nice slow deployment. Serge, how are you doing up there?
We're doing good.
Okay. So I think everything is kind of in position. I'm going to go this way, and I'm just going to push the wire a little bit. We'll bring us backwards.
Once the valve is
think the pressure will improve quite a bit.
Okay, you happy there?
Yeah.
Okay, pacer on, please, at 200.
Okay, good.
Okay, you can start going up. I'm gonna just push
Forward.
you. Yeah. Yeah. Good, I like that.
Okay, I'm going to go for it. 2, 3, 4, 5. Pacer down.
Okay.
We're
And
going to
then-
do it one more time.
So there is already a nice flare, but let's just hit it a little bit right there. I'm gonna give you 1 extra cc.
Yep.
Whatever. How many cc's were in here before?
So it's +3. We're going to +4.
There you go. All right, so we're just gonna flare here, Serge. Then we'll
Yep.
get out of your way, okay?
Okay.
Pacer on again to 160, please. Okay. Okay. Go
Ready?
ahead. Yeah.
2, 3.
Okay. Pacer off.
Down.
That's down. Yes. Thank you. Okay.
So
Let's
get
just.
better now.
Yeah. Might need more.
Okay. Yeah.
Oh.
Okay. There you go. So now we're gonna let her recover for a minute. Well, this comes out. And walk that back, please.
A little bit more wire. Thank you.
All
I
right.
have it.
And then we're gonna take the Direx back.
And
Please.
2 bolts.
And here's 2 zeros, so we're going to measure outflow tract gradient first. Okay. And not 0, but wasn't 0 before either. So we'll record that, and then if you can let us know, James, what the outflow tract gradient is, that'd be great. And then we're going to move the the aortic pressure over to LA pressure, and we'll get a mitral valve gradient. But
Okay.
all right, so there's our, there you go. Okay, now we're going to pull back from across the, nothing across the valve any longer. Put that up there.
Your nuts.
Yeah, and then Serge, if you could just take us through what
Oh,
you're
the nuts.
seeing here as you.
So I have on the right bottom image, I have the on-fast view of the new transcatheter mitral valve with the aortic valve at 12 o'clock. And on the clock face, there's looks like a small paravalvular leak at about 11 o'clock, and
Okay.
maybe a whiff of a leak down at the 7 o'clock.
Okay. Okay. I think so. Not totally perfect, but probably tolerable for now. And then what kind of gradient are you getting across that
I'll
valve?
measure that now.
And a heart rate of 90. Okay, so mean gradient of 2.
Yep.
Terrific.
Before it was 9,
Yeah.
under general anesthesia.
Sure. And how about the left?
LVOT.
Yeah.
Yep.
Thank you.
It's not bad.
Yeah.
The same as before. Max gradient was 5. Mean gradient was 2 before. Now it's 6 and 3.
Okay. So at this juncture, we have. Let's take a little cine. We'll just show the valve here. So there is the valve, nicely anchored within the annular calcification. So we've got a new valve in there. A gradient across the valve under general anesthesia is 2. Outflow tract gradients are in the low single, or well, in the single digits to teens, depending on the hemodynamics versus the echocardiographic measurements, but certainly something we can manage with beta blockers. She should be on anyway for her coronary disease, and some hydration. We've done alcohol septal ablation, which will continue to apoptose some of that septal wall and make more space there. We've done lampoon, which has spread out the anterior mitral leaflet, which thank goodness for that, because you can see that the ventricular side of the cage is touching that interventricular septum just below the aortic valve. And then she got a stent out of the deal too that we didn't see coming. So I think at this point we've got a small residual paravalvular leak. We've got some residual disease in the left circumflex. But all in all, blood pressure is a MAP of 100. She's tolerating things quite well. I don't know. You think we need to do anything further? Or?
No, I think that was very nicely done, Jamie. And I think, as you said, we can always bring her back if we need to.
Yeah. Yeah, I think, Gabriel, are you comfortable leaving that little
Absolutely.
paravalvular leak? Yeah, I think that'll be fine. So long as it doesn't create some hemolysis, she shouldn't ever notice that. So, all right, Serge. So we're what, 4 or 5 minutes post valve
Just
deployment, and we just took another look, and interestingly, looks like that anterior lateral PVL has gone away largely.
It looks like the 11 o'clock and the 7 o'clock PVLs are essentially, they're gone. I don't see any color flow through there, so they're sealed off.
Yeah, terrific.
Very nice.
You just have to wait a second. It's going to heat up, as they say. It's going to heat up. It's going to expand. That's terrific. Well, I'm glad to see that. That's a really nice result. All right, with that, I think we'll sign off. We're going to just clean up here a little bit and get the sheaths out, but we're so pleased to be able to show you this case of transcatheter valve in MAC with balloon-assisted lampoon and alcohol septal ablation and a little PCI. And we hope you really enjoyed it and found it educational. And look forward to seeing you soon.